Hello, everyone. My name is Cormac Duff. I'm a pediatric specialist registrar working at Galway University Hospital, and today I'll be presenting the most amazing X-ray you will ever see in your entire life. So an introduction to this case, this was a 14-year-old girl who was referred by her GP and brought in by ambulance to Galway University Hospital Emergency Department. She had a background of quadriplegic cerebral palsy, and she presented with a vague history, a 12-hour history of lethargy and malaise. Her oxygen saturations were in the low 70s in the ambulance, and in the ambulance she was given a dose of IV ceftriaxone. So looking at your differential, if you're anything like me, you might think immediately of sepsis. She arrived in red rhesus with her parents, and I took a focused history from them. She had had a 12-hour history of worsening lethargy and malaise. She was nonverbal, and she also had anorexia, so decreased appetite over that time. Of note, she was feeding entirely PO and did not require peg feeding. She had had no flatus or bowel motions in the past 24 hours, which was highly unusual for her. She would normally have a bowel motion once a day, and her parents would change her, so they were very familiar with her pattern. And of note, she was burping excessively over the past few hours. To give you a little bit of background about this patient, she was an ex-premature baby. She was born at 31 weeks, and she had extensive resuscitation at birth. She had neonatal encephalopathy, which was most likely due to her birth hypoxic ischemic insults. This left her with quadriplegic cerebral palsy and a severe intellectual disability and an inability to speak. She also had epilepsy, scoliosis, and bilateral moderate hearing loss. She also had, if you can see it, the bony abnormality here, extensive scoliosis, which did not require surgery. Furthermore, if we look at her hips, you can see that her hip joints were out of position. So she had a bilateral hip dislocation, which is most likely due to her increased spasticity or increased tone of her hip flexor muscles, which over years had literally pulled her hips out of their sockets. Interestingly, in most patients with cerebral palsy, this does not cause pain or discomfort. So to go through her initial management, we saw her in red rhesus, we ensured her airway was patent, we put her on high flow oxygen, inserted a second IV line, and contacted our pediatric consultants on call. So just like medical school, we went through our A, B, C, D, and E. For the clinical examination, the patient was very pale and peripheral cyanosis. She had these blue lips and looked really grey and washed out and awful. She had a grossly distended abdomen, which her parents commented on. And on examination, it was tense and tender with guarding. I tried to palpate it myself, and she literally pulled my hand away from her. So even though she was nonverbal, she made it very clear she didn't want me touching her abdomen. Her bowel sounds were also absent on clinical examination. She was tachypnic at the time. However, her lungs were clear to auscultation with no wheezes or crepitations. Her oxygen saturations were 72%, despite being on 100% oxygen on arrival. She was tachypnic, as I mentioned, with a respirator of 42, tachycardic with a heart rate of 154, and hypotensive with a blood pressure of 80/48. So updating her differential diagnosis based on this clinical examination, we were thinking perhaps she had a GI perforation. Maybe there was a recent small bowel obstruction, a volvulus, or even a gastric or duodenal ulcer. Alternatively, she may have developed spontaneous bacterial peritonitis. Of note, she did not have a VP shunt or any other exogenous cause of peritonitis. So our initial investigations, we performed a venous blood gas. We did an FBC, CRP, SMAC, which is just U&E and LFTs in Galway. We did a coagulation profile, a portable X-ray of her chest and abdomen, and we took blood cultures when we were inserting our initial IV line. So when we looked at her venous gas, we could see right away some obvious abnormalities. Specifically, she had a metabolic acidosis. Her pH was 7.18, her bicarb was 15, and her lactate was 4.9. So this was a lactic acidosis. And of note, her glucose was 12.1, so it was elevated when she came in. So we ordered our portable chest X-ray and abdominal X-ray, and this is what you all came here for today. So, as you may see in this picture, there is an absolutely massive pneumoperitoneum. It extends all the way from her diaphragm to her liver. And when I saw this initially on the portable X-ray machine, I didn't believe my eyes. I thought I was seeing the liver at the time. But when I saw it on the computer and with the confirmation of the radiology report, she did indeed have a huge pneumoperitoneum, likely due to a perforation of a hollow abdominal viscus. So we didn't know exactly where this perforation was, but we needed to get to the root of it ASAP. And just to let you know, that is the highlight of the presentation, and it all goes downhill from here. So we organized a surgical review. The surgical registrar and consultant, Mr. Carroll, came down to see her. They agreed that she had a GI perforation. She was in critical condition. So remember, she was hypotensive, she was tachycardic, she was in no state to be transferred to Tempest Street or Crumlin. So an emergency laparotomy was arranged that afternoon. So her initial management in ED included 2 IV fluid boluses because of her hypotension. She received broad spectrum antibiotics, so specifically tazocin and gentamicin. We took a group and hold before she went to theatre. We kept her NPO pre-op, and we inserted an NG tube. And of note, when we inserted the NG tube, we couldn't get any gastric aspirate from it, which will be important later. Anesthetics reviewed her and inserted an arterial line just before she went to the theatre, and they intubated her at that time. So on the emergency laparotomy, it was revealed that she had a 1 centimeter gastric perforation. This was right beside the gastroesophageal junction, and of note, there was no evidence of any gastric inflammation or ulceration around the perforation, which was unusual. Normally, we'd expect to see evidence of gastritis in the context of a gastric perforation. There was 1.5 liters of fecal and peritoneal fluid, which may go some way to explaining her massive abdominal distension. And the gastric perforation was successfully closed with primary closure and an omental patch. So as I mentioned, this perforation was near the gastroesophageal junction, specifically at the lesser curvature of the stomach, which is unusual because most perforations are at the greater curvature and are typically more distal in the stomach, close to the pyloric canal. So post-operatively, she was admitted to ICU. At this time, she was still ventilated and she was sedated with propofol. She required noradrenaline at this time because of her persistent hypotension. She was on IV maintenance fluids. We were measuring her urine output for her fluids ins and outs, and she was receiving analgesia. So she was getting morphine IV in addition to a rectal sheath infusions. So this was, I hadn't seen this before, this was 2 small catheters that were placed in her rectus muscles. So with her laparotomy, her rectus muscles were opened at the linea alba, which would cause a huge amount of pain locally. So this worked as a local anesthetic going into the rectus sheath muscles to decrease the amount of pain she was having without having the negative side effects of large amounts of IV morphine systemically. She was also receiving diclofenac PR. So diclofenac is one of our favorite medications in ED, and it's interesting that the ICU doctors like it as well. She also had abdominal drains in place. I mentioned she had a huge amount of abdominal fluid in place, so this helped drain it. She was on antimicrobials, so she'd previously been on tazocin and gentamicin, as I mentioned. We added a metronidazole for some anaerobic cover, given her feculent fluid in her peritoneum, and also fluconazole to prevent against any fungal infections, given the fact we'd just inserted 3 abdominal drains. We kept her NPO for the time being, put an NG tube on free drainage, kept her NPO and started an IV PPI. A central line was inserted and she was commenced on TPN post-op, in addition to daily blood tests to check her electrolyte levels, specifically magnesium and phosphate. So you can see after the operation that she had her pneumoperitoneum was greatly resolved. And I figured out afterwards, one of the reasons her saturations were so low when she came in is that there was a huge amount of pressure on her, upward pressure on her diaphragm, on her lungs, that were compressing her lungs. So there's a huge amount of splinting that were stopping her lungs from expanding fully. And that's one of the reasons her saturations were so low when she came in. And you can see in place here, the abdominal drains, the rectus sheath catheter, and her endotracheal tube. So I spoke to her parents to let her know how the operation went and answer any questions they might have. They added some interesting information at this time. So this patient went to a special school and she did not like being in school at all. But she'd figured out herself that there is an easy way to get out of school. That if she was having vomiting, that the school would have to presume that she had a risk of viral gastroenteritis and they would send her home. So she had figured that if she self-induced vomiting by eliciting her own gag reflex with her hands down the back of her throat, that she'd be able to get off school. And she had been doing this every day for the past 3 years. So there's a chronic history of self-induced vomiting. And this made me think, made me have my house moments. Here was a patient who had chronic self-induced vomiting. And with the self-induced vomiting, there's a sudden increase in intragastric pressure to get all that gastric contents outside. And she'd had a spontaneous perforation, which was proximal to the gastroesophageal junction, right beside where the stomach meets the esophagus. And I thought, what if this was a similar mechanism to Barrett's esophagus, where people who have frequent vomiting, often self-induced, can have a rupture in their esophagus due to the increased esophageal pressure. I thought, what if this is the exact same mechanism happening here, but causing a gastric perforation? So this patient had an excellent post-operative course. She was extubated on day 1 post-op and was actually transferred to the pediatric ward on day 2, which I was very surprised about how quickly she recovered. Her TPN was gradually weaned over to enteral feeds. On day 5, she developed a lower respiratory tract infection, which makes sense given the fact she had a lot of discomfort in her abdomen and probably didn't want to inhale deeply. Because of her severe intellectual disability, she also had limited engagement with chest physio and was unable to do insensitive spirometry. So when she developed her lower respiratory tract infection, we started her again on IV antibiotics, gave her some chest physio, and started her an Airvo to keep her oxygen sats up. Over the next few days, she continued to recover well, and on day 7, we were able to remove the last of her lines, including central lines, abdominal drains, and those rectal G catheters for her post-op analgesia. So you can see at this time, all the lines were out of her, and she had a mild atelectasis of her bases bilaterally. On day 11, she was discharged home, and we discharged her home on lansoprazole. So even though she was 14 years old, she was weighed only 26 kilograms, so this is a low-dose lansoprazole. We made sure to link her in with the community dietitian, community physiotherapy, and occupational therapy to help with her recovery. And she had outpatient follow-up arranged with the neurodevelopmental team, with surgical team, and the neurology team. And her recovery has been excellent. In fact, I saw her last week on the pediatric day ward for some routine bloods. So to discuss this case, this patient had a complex neurodevelopmental history. So quadriplegic cerebral palsy due to difficult birth, severe intellectual disability, was nonverbal. Because of that, she had a very nonspecific presentation. She wasn't able to vocalize. She wasn't even able to, to scream out in pain as another child might do in a similar situation because of her severe abdominal pain. So this must have been incredibly distressing for her. And we do find that children with cerebral palsy can have an increased pain threshold. But for someone to have a stomach rupture and a huge amount of fluid in their peritoneum, that can't be comfortable. There were a couple of clues in both the history and examination that helped me figure out what exactly was going on with her. To start off with, her parents gave an excellent collateral history in emergency departments. They mentioned that she had no bowel motion or flatus, which was very unusual for her. Remember, they're changing her pads every morning, and that she'd had excessive burping. On clinical examination, she'd had a huge amount of abdominal distension and had absent bowel sounds. On X-ray, we'd had the pathognomonic finding of a pneumoperitoneum. So if you're ordering an X-ray in this case, it would be a erect chest X-ray, which would show a large amount of air underneath the diaphragm. And she'd had a failed NG insertion. So when we had inserted the NG tube, we weren't able to get any gastric aspirate. And that made sense because a lot of the gastric juices were just going straight into the peritoneum through that 1 centimeter hole in the stomach. So to talk a little bit about gastric perforation, it can occur rarely in childhood at any age. It most commonly occurs in preterm neonates and most commonly occurs at the pylorus, which makes sense because that is where all the stomach acid is kind of building up at the bottom of the stomach. Typically presents with abdominal distension and with vomiting. Of note, this patient did not have vomiting. On a chest X-ray, it shows a pneumoperitoneum, and this is a surgical emergency, needing a laparotomy and surgical repair right away. And it has a mortality rate of up to 30% in children. Long-term complications can include a gastric ulceration at the site of the perforation. So this is why we put her on a PPI like lansoprazole for going home, even though she didn't have any previous history of gastritis or ulceration. There's also a risk of recurrence perforation. So where there is a weakness from previous perforation, it's possible she may perforate again. And rarely there can be a risk of a gastric outlet obstruction. So I mentioned that most of these perforations occur in the pylorus. So significant scarring can take place here, which may cause obstruction in rare cases. So to summarize this case briefly, this was a gastric perforation in a patient with quadriplegic cerebral palsy, nonverbal with severe intellectual disability. She'd had a history of chronic self-induced vomiting for secondary gain. She required an urgent laparotomy and repair in theatre, and she made an excellent post-operative recovery. Thank you for your time.
Goodbye, Cormac Duff. Though you were working on call, you recorded yourself, projected on the wall. The case was gastric perf, quadriplegic cerebral palsy, diagnosed on X-ray. It needed laparotomy. And it seems to me like you made your case despite the short staffing, never knowing if the audience would be laughing. And I would have liked to meet you, but you were still on call. I hope you're not too busy there in the hospital.